with this idea that these stem cells are going to be in their body for a year. Oh, great. It's going to be working. I'm not going to do anything. No, these stem cells live for maybe a few days. It's the signaling process that it creates to start regenerating cartilage, reducing inflammation, that patients start getting results from. Knowing that they're only in your body for so long means, yeah, it's going to start that process, but how can you enhance this process that was just started? Eating more anti-inflammatory foods, maybe conditioning the joint, getting it stronger, putting less stress on the joint, losing weight, drinking more water. All these things we know that are just only going to enhance this process that was started.
Osteoarthritis, it's either the lack of movement or function of a joint or an area of joints, which the body then just breaks down over time with lack of space and diminishes the space. Because if the brain says, okay, if we're not utilizing this, it's not going to send resources, valuable resources for the maintenance of any joint throughout the body. So looking at the stem cells and how well it can affect some of the cartilage around there for a chronic condition like that says a lot on how well you can regrow, rebuild certain parts of the body.
Welcome to the Functional Code, your go-to source for decoding optimal health. Join Dr. Addy and Dr. Jace as they break down the science behind pain, performance, longevity, and more, making complex concepts easy for you to understand and apply in your life. Your journey to a healthier you begins with understanding the Functional Code.
Welcome back, everybody, to the Functional Code, episode 29, part 2 of the Regen series. We're talking about pain and joint health today. I think this one's going to be great for everyone just because we know that this is usually where we first start talking about stem cells and especially now exosomes. Today, we're going to talk briefly about the differences between stem cells and exosomes, but mainly going to dive into, I would consider, the 4 or 5 main conditions that we're seeing it being affected as far as low back pain, knee pain, shoulder pain, or even a rheumatoid arthritis and other issues like that. Dive in with us today. We're excited to have you. And as always, I am Dr. Addy.
And I'm Dr. Jace. Super excited for this one, especially for us being chiropractors in this field. There's a lot of awesome gems and tools that if you are a physician of any sort, that this can help out a lot with results for your patients, which we're super excited to bring some of this knowledge up front and dive into possible questions that you may have, that you might be thinking through this episode. Doc, I know we brought up the differences between stem cells, exosomes last episode for skin, hair growth, and wound healing. Now, for this, obviously, we're looking at probably deeper structures. So with that, let's get caught back up between the differences between stem cells, exosomes, especially relating to the topics today in terms of joint health, pain, arthritis, all that.
Yeah, absolutely. So when it comes to, let's use knee osteoarthritis as an example to get started. With the main cause of osteoarthritis is the loss of cartilage, the loss of space. Bone on bone, maybe is another word we hear a lot. We have the ability now to actually try to restore the cartilage that has been lost with stem cells. The difference between stem cells and exosomes would be in stem cells, they have the ability to turn into chondrocytes. Chondrocytes then grow cartilage, and that is then going to promote cartilage repair. That's just one example, but now they do have the ability to reduce inflammation, modulate the immune system. They have a lot of other abilities, but in the case of osteoarthritis, 2 of the main things that I would say stem cells can contribute to is not only the reduction of inflammation, but the improvement of cartilage regrowth. Now, when it comes to exosomes, they have the ability to deliver the, I would say, components to reducing inflammation. They have the ability to deliver the growth factors needed to grow, also with cartilage and those kinds of things. So you have exosomes as the delivery vehicles of what is needed, and then you have these stem cells that turn into the head coaches that kind of start the process in a way. So that's already number 1 going to be the main big difference when it comes to treating something like knee pain or knee osteoarthritis. Now, it turns out when they take a look at the research of doing stem cells versus exosomes, especially with arthritis, you see a lot of the same outcomes. So it's difficult to take this idea of when should I use stem cells versus exosomes. So it doesn't even have to be a difficult question, because in this case, this study showed significant improvements in pain scores and functional outcomes in osteoarthritis patients treated in the joint with stem cells. This was a study you can find, and we'll post all of this too for everybody so you can find all these studies. But you have a contrasting exosomal injections study showing that it reduces pain, inflammation, but clinical efficacy in comparison is still under investigation and is less established. So the one that I posted showed similar outcomes, but you'll find a lot less research on exosomes compared to stem cells for knee osteoarthritis. So
Especially human research studies.
Especially human research. So that would be another difference, is you're going to find more research on stem cells versus exosomes, but the ones that they've done with exosomes have similar results to stem cells. It's just what more do we need to understand before we create this standard protocol, gold standard. Regenerative potential maybe is another question. Stem cells have the ability to regenerate cartilage by differentiating into these chondrocytes like we've talked about, which directly contributes to tissue repair. But exosomes don't turn into anything. So they don't directly act on cartilage regrowth. They are the communicator, the modulator. So they're absolutely helpful in enhancing healing, but they aren't the ones that you would consider as a direct effector on. So the real question would be, okay, once I heard that, why wouldn't I just use stem cells then instead of exosomes? And that's a great question, because a lot of people are still just doing, from the circles that I have of providers, they are arguing that exosomes are better than stem cells when it comes to injections in the knee and even in the joints. There are theories that exosomes are too small and they tend to leak out. That's one theory that I've heard. I don't know if we have enough research to show that. The second would be, and you could probably argue that with stem cells too, if they're going to come at you with that theory. I don't know if that's technically the one thing that I would state why I would use exosomes versus stem cells. For me, it's going to be the fact that we've seen more literature of stem cells, and so I'm gonna be biased towards stem cells, because I want to make sure that if I'm gonna do exosomes, it's gonna work. And with exosomes, you're starting, like we talked about in the last podcast, you're starting to see them used more for healing of the skin or superficially, and then we don't have quite enough knowledge done, like as far as joints or something deeper. Yes, we've seen it done on like deeper wounds or lacerations, but we may still have to have more research when it comes to like joint health and especially pain too. And then just lastly, when it comes to the differences between the immune system, stem cells tend to elicit more of an immune response, but they still are immune modulators, and they don't have this immunogenicity that we would think that would cause a rejection. We still have yet to see any research or studies showing or having happened with donors. If you've done stem cell therapy, or at least in the research, we've never seen in literature a case of a rejection as far as a mesenchymal stem cell. So even though they do elicit more of an immune response, that's not the response that we're seeing. We're seeing a very healthy response. It helps to modulate their immune system. Now, when it comes to exosomes, they are acellular in nature, so they don't provoke an immune response at all. Even if it, like, ever. Like, not to say I don't want to say never, but way more or less likely to even promote an immune response. Why that's helpful is because if you're trying to, let's say, reduce inflammation in the face, where you don't want to provoke an immune response at all, because you don't want to have puffy red face, that's where exosomes are starting to be helpful, is because you don't see that kind of reaction. Suitable for that administration versus stem cells.
So going back to, I know last episode we brought this up, and I think this is even more important for the topics we're talking on today in terms of the site of delivery and how we administer it, and the reason why. So last episode we briefly talked on when you get some of these therapies, whether it's stem cells, exosomes, into your body from an acute accident versus a chronic one, will affect the stages of healing. So ideally getting this done sooner than later will have a way better effect.
Yeah.
But even for the site at where you apply some of these therapies, so especially in terms of injections. So if you, Doc, if you want to bring up the thing with the knee when they introduced the stem cells intravenously.
Yeah. Right. So by and large, if I'm going to try to manage a knee issue, I'm going to inject the knee with stem cells. That's going to be just your foundation. But what we've been finding and what they've been seeing is if you've administered these products intravenously, we have reduction in pain in these patients that had joint issues or pain elsewhere. So let's just say, for example, you were trying to make a difference in someone's lung health, maybe brain health, and they were using that intravenously. They found these patients were actually stating they had less pain overall, even had less joint issues. That's what some of the anecdotal evidence I've been told from providers, and even in myself in practice with it. So it's interesting that you can take these products, introduce them intravenously, but still get effects elsewhere. Again, you can obviously theorize why that would be a thing, but I think that the most importantly, when it comes to trying to change cartilage health, you're going to want it to be as close as possible. Even though stem cells can migrate, they're not alive for a long period of time. So I'm going to want to get them as close to said site as possible before they obviously die off, which is what we talked about in the last episode, very quickly, within maybe days. That's going to be something that I'm going to use in my thought process of why I would use one versus the other and why I would administer it that way versus the other.
Love it. And yeah, thank you. And there's certain parts that we're going to bring up that may have been in past episodes that we think that are more important for some of the topics we're touching on. So you may have heard some of this stuff previously. We may say it a different way, but there's a purpose for this. Doc, yeah, I love the analogy you have used in the past. Stem cells, head coach, exosomes, assistant coach, but they all help facilitate the healing and different properties that come with it. So as we go into arthritis, especially for the knees, because a lot of the research is usually for humans is done with the knees. So I guess let's look at some of the mechanisms for stem cells for the knee, and then we'll look at with that certain areas of exosomes as well. But Doc, stem cells and knee arthritis.
Yes. So I broke it down to help you understand the difference between stem cells and exosomes. So we're going to start with stem cells for all these conditions coming up. And then we're going to move to exosomes and do the same exact thing. And that way you can get an understanding of why one works differently versus the other, but how they both can absolutely contribute and enhance these issues that we're about to talk about. So knee osteoarthritis, by and large, my theory, and I think most of the research is showing, is they can differentiate into chondrocytes, which contribute directly to cartilage repair. And when we can start repairing the cartilage, that is going to improve the joint glide. It's going to overall help the condition of the joint health, and it's going to give you the ability to gain some space back in that knee, which I think is pretty amazing. We didn't really believe that we could ever do that before. We didn't think that we could gain any space back after space was lost in the knee. We're still trying to see if we can gain space elsewhere, like in the back, vertebrae, or in other parts of the body. But we do have good research showing it does promote cartilage repair and growth. So that's awesome. Another thing it does is secretes growth factors, which can stimulate proliferation of extracellular matrix, like I said, cartilage, but just other cells that contribute to healing. Second thing that I would definitely argue that it can help with in as far as osteoarthritis is it just has anti-inflammatory effects. So they modulate the immune system. It can induce T cell regulation. It can secrete anti-inflammatory cytokines, which inhibits, obviously, pro-inflammatory cells, macrophage T cells, and it reduces the production of these inflammatory components. So we see that in the literature, and I think a lot of patients understand arthritis as an inflammatory condition, an issue. It's a condition of swelling, not fun to move when it's swollen.
And a chronic condition.
Chronic, not a lot of space, it hurts to move, pain sometimes during the day. There's definitely an inflammatory component to it. We know that, but when we take a look at why you could make a difference in osteoarthritis, one versus the other, I think those would be the two main things that most researchers are arguing right now why stem cells are making a difference. Moving to how they've applied this, where they've taken this in research and obviously applied it into clinics. I took two of the more larger trials that they've done on humans and explains the differences between bone marrow stem cells, and the other one was done with adipose stem cells. So again, you get a little bit of mixture between where they're taking these stem cells from, which I think we talked about in the last podcast too, why you would want one versus the other. But not only that, how it can make a difference between taking one versus the other too. So it is interesting that these outcomes happen when you are looking at the differences, but to the good stuff, right? When they took these patients, 30 patients that received an injection of bone marrow stem cells that had knee osteoarthritis, and they compared it to hyaluronic acid, which is a very common injection, especially with patients that are above the ages of 55, 65. I know Medicare used to pay for HA really well. I think they maybe still do, but it's a rooster comb injection is another name for it. It's just the components that you can find in bones and cartilage that when they extract, it's very viscous, and when they put it into the knee, it's a gel-like structure. It can help with glide, it can help with pain, but we're still trying to understand just how effective HA is compared to other things like PRP, stem cells, that kind of thing, even cortisone. These patients received either HA or stem cells. The stem cell group showed significant improvements in pain, function, and cartilage quality via MRI at 12 months, better than the HA group. Obviously, we have studies showing efficacy differences compared to either placebo or HA. Now, the bigger trial, this was 100 patients. This was with stem cells. This was done, I believe, in 2019. Again, the patients were either a placebo, so the comparison was just, I believe, saline versus stem cell.
And just to remind you guys, with arthritis, it's usually, for most arthritis, especially osteoarthritis, it's either the lack of movement or function of a joint or an area of joints, which the body then just breaks down over time with a lack of space and diminishes the space. Because if the brain says, okay, if we're not utilizing this, it's not going to send resources, valuable resources for the maintenance of any joint throughout the body. So looking at the stem cells and how well it can even affect some of the cartilage around there for a chronic condition like that says a lot based on how well you can regrow, rebuild certain parts of the body. So for example, this would be obviously a little bit of joints, but even with that, what Dr. Addy was also saying too is the rehab and the maintenance of what you're doing along with the stem cells matter just as much because of the signal that was coming. And then you add in the physical therapy, maybe let's say chiropractic, or for example, for the knee, distraction of the joints so you can allow more synovial fluid to the edges, and then also allow your nervous system to communicate to that joint for lack of guarding tension, which also allow more blood flow in, waste products out, thus accelerate the healing. So what you do with the stem cell therapy, the exosome therapy matters just as much, but this will help significantly from internal state function-wise more than what we've seen in past treatments.
Yeah.
Thus with hyaluronic acid.
And when I was practicing with these products, what I found was I almost presented it to these patients as regenerative rehab. It's rehab using regenerative products, but you're rehabbing, you have to rehab. So we're enhancing this rehab, giving you the ability to maybe get more out of this joint using these products, but also maybe giving you an edge to what you're already about to get into, because yes, you're going to get into that. Like, it's not a skip, it's an enhancement. With the patients that I had, if they weren't willing to go through that process, then I very well made it known that they weren't going to see the effects that they wanted to see. So, and oftentimes there are plenty of provider clinics out there that just take patients on and do this injection and don't have them do any other types of follow-up or effort or work. And I would very strongly state you're just wasting your money. So be cautious doing these procedures if you don't have that mindset. Because if you're here expecting to hear a new miracle one and done drug, whatever have you pill, that's not it, and we don't have it yet. But what we do have is the ability to now take the joint you have, bone on bone, delay or even prevent surgery from happening, and giving you some health status back into this knee joint that you probably wouldn't have gotten by yourself. And obviously, if it's truly to the point where it needs surgery, it's going to give you at least some delay, possibly, or even just starting rehab. Sometimes you can't even get to that point. And so reducing some pain, giving you some space, and now you have more motion and function out of that joint. Perfect. Now use it. Get to it. Don't be happy that you have that now. Like, no, it's now time is ticking. You just were able to regain some function you never had. You were almost have surgery. Get to work. Now use that knee, put some load onto it, and get it back to health. You revived a dead joint in a way. We didn't have that ability before. So that's where I want patients to understand as far as a mindset of using these products. Don't use it to dig you out of a hole of how many years of bad habits. If it gets to that point, hopefully we can still bring you back a little bit, but we're not going to revive you to a 20-year-old knee. That's not what stem cells do.
At least not right now. There's the connection between brain and tissues, and you got to increase that signal significantly. So, man, I love that. So I guess with stem cells, I know a lot of research has been done, like we said, mainly on the knees, but does it also affect any other joints, or what is the literature that you've seen thus far with that?
So the basis of helping other joints, or even just how it could help other joints, especially if the joint doesn't have a lot of cartilage, maybe, like comparison to a knee. So you'd want to understand how stem cells can impact other ways of tissue healing and regeneration. So they can also promote the regeneration of damaged tendons, ligaments. Obviously, we talked about cartilage. They can change epithelial, skin cells, all the things that we talked about in the last podcast. So they have the ability to change into other structures that joints are made of. And that's where, again, we see changes in shoulders, backs, other areas than just knee, especially even showing in literature now. You have the kind of the same process there with the anti-inflammatory component, but then also the ability to build up structures that joints have to improve its health, other than cartilage that we talked about. The only other way that I would maybe state, like coming up, we're going to talk about RA, would be its ability to modulate the immune system. So we know RA is autoimmune issue where the body starts attacking its own joints. And that's where we have now the ability to maybe downregulate that process. So stem cells can reduce production of antibodies and inflammatory cytokines, which obviously RA plays a role into that. And we're seeing that in other autoimmune issues too. So in the case of other joints, and obviously RA being that's where stem cells are going to have an effect on. So we have, just take, for example, they've done a lot of studies on rotator cuff tears. And this was done with adipose stem cells for the treatment of full thickness rotator cuff tears. Now, meaning the entire muscular tendon junction was severed of that subspinatus. With a full thickness rotator cuff tear, the MSC group compared to placebo had greater improvements in tendon healing and shoulder function compared to just placebo alone. And that is important because too many times, I know you've heard it, you get a patient in who has a rotator cuff issue and they just want to do surgery. They just want to anchor it. And we had a great shoulder podcast way back in the day talking about why that surgery shouldn't even really be performed anymore in a lot of cases. Compared to rehab alone, even just exercise alone, we know that there was better outcomes in certain cases. So now you add in, of course, the ability to do stem cells plus rehab, you're going to get probably even better results. But that's where we're starting to see now not even needing surgery for some of these cases too.
So if you guys don't understand, there's mainly 4 different muscles with a rotator cuff, but the main one that is most commonly affected, like Dr. Addy said, was the supraspinatus, which controls raising your arm at least to 90 degrees, and it's on the top part of your shoulder blade / in your shoulder. Exactly what Doc was saying, when you incorporate some of these stem cells, the body will naturally heal itself. And then even if you look back at the knee podcast that we did with Connor McDavid, and he didn't even have surgery.
Yeah.
And just what he went through for his body to heal itself says the tremendous potential for many humans to go through and have success with some of this stuff. And going back to what we said earlier, it depends on what therapies you do with this, but just the fact that stem cells, exosomes, and all these regenerative medicines will have a huge effect on the healing process. But now going obviously to rheumatoid arthritis and how that plays into it, like this RA, from an autoimmune standpoint, it has benefits as well too. Doc, what have you seen with, or is there anything else you want to touch on with rotator cuff?
Yeah, and they've done a lot more than just rotator cuff too. They've done prevention of full shoulder replacement. They've done tendonitis of the shoulder, not just a tear. They've done partial tear studies too versus full thickness. You name it. They've probably studied it, at least in some type of pilot or clinical trial. I know we have, even on frozen shoulder, adhesive capsulitis, they have studies showing just the improvement of that condition compared to placebo. So
A frozen shoulder, if we will, just inflammation of the cap.
and yeah, so we've gone through so many conditions now over the last 2 parts. It's almost as if it'll help everything, right? And that's where I don't want to say that, because I'm never going to blanket any treatment. I don't want to create this as a miracle treatment. But if you think of it as the foundation to healing involves stem cells.
Yes.
The foundation to healing involves platelets. Who's to say that a PRP and stem cell injection wouldn't pretty much help heal anything? That's a good question. It's not really that easy though, because what we know is each platelet injection is created differently. We need so much platelets to get the job done. Each stem cell injection is created differently, because you can get these stem cells from all these different labs who extract it differently, and some are donated, some are your own. But would a 70-year-old stem cells be different than a 30-year-old stem cells? Yeah, absolutely. You're going to find that your stem cell growth reduces by about 50 to 80% by the time you hit 50, maybe even 60 years old. So yes, is it made differently, and is it easy as well? I'll just do that to heal myself. It is. It's something that needs to be more studied and researched, because if we have a 7-year-old, you take a vial of stem cells and you're to put them in a 7-year-old versus a 30-year-old, we would argue and theorize that the 30-year-old is going to have a way better outcome, because they already have higher proliferative factors, secretory ability, versus a 7-year-old. Maybe the 7-year-old is going to need more. That's the questions that we need to answer, because each patient's going to be different. And if we don't have these protocols built, then we're wasting time and money. Because if it's not just going to be a 1 shot per patient kind of protocol, it can't be. And so it's going to be this idea that you need to measure the patient of how they're doing. You need to have a baseline. You need to know how their outcomes are going to be. You need to continue to monitor that, and you need to push them to continue to do better than just getting this injection. Now, it's tough to have multimodal research, because you're always going to want to have the least amount of variables possible. So that's tough to state, oh yeah, this guy did stem cells, rehab, and all this stuff, and he was better. Now, how do you do that across the research. You just can't. So you have to be comfortable knowing there's not going to be perfect research to explain all this in one day. Like there's will not be in one point in time, even in the next 50 years, that's going to explain a perfect protocol on how to regenerate this knee osteoarthritis to its full extent. You just may not get that.
There's so many other factors.
There's so many factors. So what we're going to have is now the groundwork laid of a lot of these practitioners who are taking this science and applying it, and then just experimenting, trying to figure out protocols and how many injections versus this age group versus this age group. And there are some companies out there that are doing that. They're doing a pretty good job. Regenix is one. They're I believe they're out of Cali, but they have all over the nation now. I think they're starting to get there, but I like it because they're extracting data and they're doing their own research. I shared with you the other day about the TMJ.
I was just going to break that up. Yeah.
So obviously Dr. Jace is incredible when it comes to jaw health, understanding how to treat jaw issues. And so I had shared with him in a study that they had done, and I believe it was 127 patients.
Yep.
And they did a injection into the jaw, and outcomes were better opening and less excursion. Was that
lateral deviation?
Yeah.
Yeah.
And so, Doc, obviously treating patients with jaw, your issues that you've obviously had over the years too, what in regards of struggles of treating patients with TMJ. When you saw that, obviously, what were your thoughts?
It opened up so many possibilities, because most of the time with jaw problems, it's either compensations, sleeping patterns, or whether it's dental procedures affecting how the jaw tracks, especially the disc tracks as you open and close the mouth. And most of the time, if the disc specifically in the jaw is either shifted laterally, or if you have past whiplash symptoms, whether it's via car accidents, punches, what have you with that, there's ligaments on both sides of the jaw, which will help for deviation. Knowing that it helps for the deviation is telling me directly that it's probably site dependent on how it was applied more, but also, and I didn't dive as in depth in the study as I'm going to, but for the healing of the ligaments on both sides, and for even the tendon, which will help pull as you open and close the mouth and chewing and all that. Even as we chew, there's a little bit of rotational manner to the jaw for the grinding, especially on the molars on the backside. So considering that and the influence it had, pain and all these other things, I don't even know if they did even rehab with it.
I doubt it. Maybe they did. I can't speak for them, but I'd have to look into the study. But what I do know is, and I'm sure you can attest to this too, is if there was disc damage, did that have an impact on that too? I'm curious to see, did we see some regenerative changes there?
Absolutely.
Because I'm sure, like, I think you've talked on your jaw podcast was if you do get punched and there is like the traumatic change to the disc, that can change throughout the course of their life now.
Yeah.
They don't get that back. So now do we have the ability to actually get some of that back? That's going to be crazy.
Just to even eliminate from that point and perspective too, and to also eliminate compensations, because once you have jaw pain, it usually affects the area above and below from a tissue standpoint, not even talking about neurological impact for all the brain centers and how that can affect pain systemically. But we're seeing now with certain patients, with certain populations, that when there is jaw pain for longer periods of time, there is compensations either to the front of the neck, the scalenes, the omohyoid muscle, which goes from the hyoid bone, which is the only free-floating bone in the body, and that goes and it travels to the shoulder blade, so that it can affect the scalenes and rotation of the head and shoulder problems in communication with the neck and jaw. So it affects way more than people realize, but to utilize this as a possibility for jaw pain and jaw problems itself for the rebuilding of tissues, which when you look at certain lines of literature, there's different types of cells in the jaw, different than skeletal muscle.
Okay.
And it's almost, and I almost look at this a comparison between heart muscle versus skeletal muscle. There's different properties to it. It's very similar to the jaw and those tissues involved versus all the tissues involved with, like we said, skeletal muscle, mainly because we're needing to use our mouth to talk, to chew, to yawn, to spit, to drink. So it's a very efficient tissue and structure that you need consistently working throughout your whole life. And it's something that not necessarily you want to build up strength for, but you want to allow those tissues to work properly. And there's certain rehab and literature that you can do for a person, but there's still certain limitations. And I think this limitation could be influenced via stem cells based on that study, what I saw. And that's what kind of lit up everything for me. So
that's exciting.
It's cool. It's really
cool. I know we've dove into the TMJ quite a bit, and it's obviously we said you want to get into the neuro, but just the neuro itself, that's crazy stuff too. But when I saw that, because I've actually seen a TMJ injection live with stem cells, and
cool.
It was interesting. But
where did they do it and how they do it?
Yeah, it was done in Utah, and I got to see a doc do it, and he took, I believe it was a 1/4-inch, 1/2-inch needles, very small, obviously, and he had the patient, I think the video.
Ooh,
yeah,
cool.
I could show you. But so what he did was, I believe they partially opened the jaw, and then they went in straight laterally, like perpendicular to, and I think they went right in, not ultrasound guided. So he was an incredible injector. He said, starting out, you need to do it ultrasound guided, obviously, but which I think you should always do ultrasound guided. Just throwing that out there. I didn't say that I appreciated this guy. All I said was I've seen it, but always, if you're gonna have it, I hope they're doing ultrasound guided. Let's just say that. But yeah, and he also did that day a pubic symphysis injection.
Fast.
And that was the one that blew my mind more, because it was on a patient who had urinary incontinence. And she said the day after, because it was a 3-day seminar, the day after she came back, she said that she urinated for the first time into full completion in over a year.
Wow. A year.
Yeah. She said she felt she had one of the worst cases of interstitial cystitis.
Okay.
And so she said it just always, she's like, I would go and they would stop, and then it would go and they would stop, and then I never felt like I would fully empty. And yeah, he did a pubic symphysis injection, which, if those of you aren't wondering, it's the very hard bone right around the private parts in both male and females. It's just the bony articulation that the pelvis forms. So it's not just women, men have them too. But what's interesting is obviously very close to the bladder. I don't know if there was migration involved, or if I don't know why that area worked so well. I don't. Yeah, or maybe systemic. Yeah, like you said, or maybe is urinary incontinence more of a tissue involvement, like tightness of the pelvic floor,
Never thought about
and then that's why the injection works so well. That's because I played around a lot with pelvic floor changes, and because I have varicocele on my testicle, so the cyst basically of it's enlarged veins is what you would call it, which has caused a lot of pelvic floor pain for me, among other things, reproductive things as well. What I found is I do have way more guarding in my pelvic floor, and I don't know if it's from protection of that or if it's just from other things, but I do get some interstitial cystitis symptoms here and there. But when I work on my pelvic floor, it changes a lot. It makes things way better. So now that I'm thinking those kinds of injections were done that day and what the outcome was, that's what I'm trying to play off of that and try to find other providers that have been doing those injections too. But yeah.
Even so, just thinking out loud more or less. So the pubic symphysis from a tissue standpoint, there's a little bit of a disc, if you will. It's more like a cartilage. I almost think about a meniscus of the knee is going to be similar as like the small disc space in terms of a pubic symphysis,
nice, yeah.
Of how the bones come together, but there's a little cushion, and that cushion can affect different parts of the pelvic floor. But in terms of especially walking, jumping, like any typical movements that you see, where the tailbone on the backside and the pelvis and how Each step forward or movement in some direction affects the rotation of the back of the whole pelvis itself, but even the tailbone, and there's a sway to it. Now, if you take in consideration, that's the backside, but also the pressure absorbed on the front of the pubic symphysis. If one side gets stuck on the pelvis, that can affect more pressure on the front part of the pubic symphysis. It's almost like if you put a pressure on one side of a bowl, it'll have usually a rotational guarding to the complete opposite 180 side of the body.
Mm-hmm.
So when you look at core to extremity movements, yes, you want to look at the side of pain, but also how everything affects, and the effects are on the other side and also above and below the area as well. In terms of the reset of the pubic symphysis and just even the tissue repair for that, usually contraction relaxation of whether at certain various angles of your knees bent versus legs completely straight, I'll bring your legs together, can affect different pulling tension on that disc on the front side.
Yeah.
Yeah.
And I mean, there's so much more, I think, specialization into pelvic floor now, recently too, within the last 5 years.
Oh God, yeah.
And I do think it contributes to more than we think, whether it's reproductively, whether it's pain-wise. But yeah, so that was an interesting procedure to have done that day.
And I'm glad you brought that up. So the effects of RA, rheumatoid arthritis, with stem cells, Doc, what have you found? I know there's a study that you're going to dive into.
Yeah, and I think with a lot of arthritises, it does a great job, I think due to the anti-inflammatory component. But this specific trial, not only did it help understand the efficacy of stem cells, but the safety of stem cells, which we don't have a lot of studies actually stating that in the end of the study. So this study was done on RA patients receiving IV stem cells versus placebo. And the stem cell group showed significant reduction in what we would consider disease activity and inflammatory markers. So they were measuring specific markers of the blood to explain more RA patients have uptick in these markers. So that's what they measured. The stem cell group showed significant reductions in these markers compared to placebo, and no serious adverse events were reported while doing this. So that's great, because too many times we talk about the outcomes, but not enough about just how the patients really were during the experience. And again, full on IV, done straight into the vein, no adverse events were reported. We still have yet to have one death reported in the literature from mesenchymal stem cell treatments. There very little serious side effects when you have stem cell treatments being done. But yeah, that was RA, and
which would make sense from the systemic effect versus local.
And I'm curious what maybe like a bilateral thumb injection plus an IV would look like too. If most patients with RA have more breakdown at the metacarpal of their thumb typically, but it can affect other things too. But pairing that into it, and what does that look like? And true, a lot of providers I know love to add an IV in with a joint injection because they understand the systemic effect of the inflammatory components too. But not a lot of research is that has been shown. We don't get to see that because it's an extensive procedure, and we're still working on that. But
okay, let's go from a different perspective for the systemic effect and look at stem cells and pain management then. Because if you guys haven't checked out our pain podcast, I suggest you go look at that. There's different ways that people can perceive pain, whether it's psychological, mechanical, but as you look at it as a whole, especially with stem cells affecting the whole body or local sites, stem cells can have a healing property effect. So, Doc, what have you found in terms of the mechanisms for pain management?
And this one's easier because all the studies done, that's pain scale, VAS scale is usually used. So we can see pain is always being affected in these patients. So this one's a little easier. And I put in some more chronic pain studies done so we can see that outcomes. But two bigger theories to why I think it has such an influence on pain. Number one was anti-inflammatory. So we talked about that. But number two, they secrete neurotropic factors. Stem cells do, such as like BNMF. I can go into a bunch of them, but really what that can help do is support nerve health, nerve function. It can actually reduce neuropathic pain. So this might cause an alteration in pain signals, reducing nociceptive transmission, some type of change in whether it's at the skin of that injection site, that there is now a change in mechanoreception, change in nociceptive transmission, those kinds of things too. So we have this understanding, and actually, I think they've now done, so I did this before research was even done. I guess I'm going to toot my own horn, but we used to do perineural skin injections for patients with neuropathy.
Do you want to explain what
So it's just next to the nerve. And so what we would do is these patients that would come in with feet pain, leg pain, we would take stem cells, PRP, whatever we had. It was a lot more, I talk about it like it was the Wild West, but it was very well done. We had many providers that I worked with, DOs, MDs, NPs, that all were, they were so good at what they did. And so we would use an ultrasound to get next to the nerve that we felt was probably more compromised due to the neuropathy. But we would also inject at the site of the feet and in the legs. And we had 4 or 5 injection spots that we would do. And we would do, sometimes we would do PRP, sometimes we would do stem cells, exosomes. And what we found was these, over the course of so many weeks of injections, months of injections, patients would actually start seeing huge changes in pain reduction with their neuropathy. And that was crucial because neuropathy is such a debilitating issue. It's very painful to people.
Did you see a difference between peptides, stem cells?
We saw pretty similar. We used them all. We used them all together. We didn't have just. We would throw everything we could at these patients because this was their livelihood, and they just wanted to get better. And I didn't want to sit and experiment with them, so we could throw what we could at them from our best theory, which was usually a mixture of either PRP and stem cells or PRP and exosome.
Okay.
Yep. And we ended up just going with PRP and stem cells because exosomes at the time were stopped from circulation. They actually stopped circulating exosomes due to the FDA putting a kibosh on them.
But hard to get too.
Yeah, harder to get, all that stuff. Yeah, so it was PRP mixed with stem cells, and yeah, now there are studies showing that they did this, and these perineural injections done in these neuropathy patients, phenomenal results. And so it's cool to see that they're starting to make the appropriate efforts to do the research needed. But I didn't want to wait 5 years. And that's for providers. I argue with them on that. If you understand that it's safe, that's where I guess ethics-wise you can argue with me on that. But I understood it was safe because I went and studied all of these providers across the nation. Like I said, I went to Utah, I went to St. Louis, we were in Florida, we were in Mississippi. I went everywhere. I went and did the work first. I didn't just go and experiment and start without knowing anything. But basically, that was...
Even on that front too, like physicians might know about this stuff, but it's having that conversation, not having that barrier for a physician because it's maybe not covered by insurance.
Exactly.
Because it's a cash service. Yes, it's expensive, but I think it's appropriate for physicians with the knowledge that they should know of the options available.
Yeah.
And I think that part is where most physicians, I feel, should do better, but maybe they are. But that's just the one barrier that I think gets missed at times when presenting to patients.
For sure. And I think results are going to improve when more providers talk to each other and stop looking to the research for answers. Because there are plenty of providers out there who are doing very safe, very effective protocols in this space with the research not even having been solidified or performed yet. And that's where you get the excitement, is there are probably treatments out there that we haven't even heard of yet that are being done, that are helping some amazing things, that are safe and effective. And so that's where I think more providers we need to have a way to communicate with each other about these things. And we need to stop looking for government agencies to tell us what to do, because I just don't think that's the way to go.
The behind the eight ball.
It is. And
not many other ways around.
75% of the FDA is funded by the pharmaceutical companies, just so people know. Yeah.
There's a reason why.
Yeah.
that
We won't
people
get
aren't
into
getting
politics,
better.
but I just had to throw this out there. Anyway, so
I love it.
yeah, so it has anti-inflammatory components, neuroprotective components, especially when it comes to pain transmission. The two that I included were osteoarthritis pain, specifically, that's what they were measuring, and chronic low back pain. So the first one, this was done, joint injections in the knee to reduce pain and improve quality of life. This is a RCT, randomized controls trial. So it's a randomized controls trials are higher up in the chain of effectiveness and validity. So this patients, they used what's called the quality of life questionnaire, which looks at a lot of portions in life, just from depression, anxiety, catastrophization, quality of life, all those things. And they also showed not only reduction in pain, but improvements in quality of life using this questionnaire at 6 months versus the placebo saline group.
Okay.
So that was awesome to see, because not only is it helping with pain, but it's giving patients the ability to improve other things in their life, like function and normality and quality. And pain is one thing, but we know pain and function are two independent of each other. That was great to see. Secondly, chronic low back pain. This was just one of many studies I know that they've done disc injections on. And I always like including these studies because it just shows where we're reaching to right now with the science of stem cell injections. But this was a pilot study done on patients with pain due to degenerative disc disease. And these patients were given legit injection into their disc with adipose stem cells compared to, I believe it was saline. And what they showed was at 12 months, the patients that did stem cells had far more significant pain reduction and functional improvement compared to placebo. And the MRI showed improved disc hydration and structure change.
That is huge.
Yeah.
So if you guys didn't know, degenerative disc disease is where if you have bone, the disc in between starts to deteriorate, thus where nerves, as they go out, especially for the spine, down out, they can affect neuropathy, can affect pain, sensations, a bunch of different things with that. So the fact that it can rehydrate the disc itself is incredible, because then it gets to the cartilage on both sides or all sides of the disc. And we know now that from the discs of the spine and most joints, a lot of the diffusion between one bone and the other, when there is a cushioned substance, I'm not 100% sure for meniscus, but I know of the spine, that diffusion is where synovial fluid can pick up. There's more blood flow around the edges, not necessarily in the middle for discs. So in order to regenerate tissue for the rehydration of discs, stem cells or not, you definitely have to move around the edges, ideally pain-free, so you don't have the guardian effect there. So you apply a specific rehab for the joint, and then you add on, let's say, stem cells, it opens up a can of possibilities.
Right. And we know maybe you won't get a bigger disc, at least from what we've heard in the research, but could you get a better working disc with what you have? Could it glide better? Could it be more hydrated? Could it provide more nutrients to that said disc now that we have more blood flow, and ultimately prolong the life of it?
100%. And it's crazy to see that. I know from some of the case studies that I have monitored over my career, there's certain people, spines, that can rehydrate a disc 1 to 2 millimeters at best.
Okay.
However, it's not the same across the board. I think age plays a factor. Obviously, nutrition plays a factor. And I didn't even utilize any stem cells or regenerative medicine at the same time. So I think there's possibilities. But again, this is where, as more time, specific lines of literature and research play into certain different conditions, that will open things up other than just like a pain score, but actually seeing what is the mechanisms done. But I think that will come with technology at the same time, because you can't necessarily cut someone open, or you have to have a sensor at a deeper level to monitor the improvements in some way, shape, or form. So it's hard to see how you can even put together a study for that. But knowing that we can help in a way better process. We're even seeing it for like even AC joints of the shoulder. lack of space to open those up and perform normally, I'll probably put an X-ray image just to even show that, because that is almost, in my opinion, probably a little bit more challenging and difficult because of ligamentous structures, tendon structures, and different pulling mechanisms around there than it is in comparison to the spine, but equal to their own respective. So yeah, Doc, I love that you brought that up, because I was actually going to ask that question too today. Dude.
Then you talk about what's your alternative, right? So you jump into the fusion question, right? If you have chronic degenerative disc disease, and we understand what's going to happen when fusion gets introduced into someone. So we talk about that on several podcasts, definitely our low back podcast, but it might even been sprinkled in somewhere else. But we know what quality of life patient is probably going to have after fusion. Some you hear, yeah, my dad had it and he was good the rest of his life. I'm like, was he though? I don't know. But I would argue that. But what I do know is if a patient does need fusion, I would argue that it probably came from a severe car accident, or they just needed to really maintain the spinal column. But to a chronic progressive disease like disc disease, you don't have to jump to that. And I know Doc Jace talked about that on the last the back podcast, was you should exhaust literally all options. And it should be over the course of years if you have to. And I know it sounds miserable, but if you do dive into this as best as you can, you're going to see results. And it may take years to get you 100% better, 95, maybe not 100, but at least you didn't resort to something that will, in my opinion, reduce at least somewhat for certain your range of motion and your ability to impact load on that area. But quality of life, in my opinion, I've talked to too many that have lost it because of fusion. So that's why I'm so strongly opinionated about it. But now that we have this ability to hopefully delay that, but then you talk about the other alternative of the cadaver bone disc or the cadaver disc, the spacers, all that stuff. Those are dead. They're not living. And I would almost put it as if you put that disc, the cadaver disc in there, it now acts as a spacer, but the disc does so much more than just being an extra space for the vertebra, for the nerves to come out. It acts to have imbibition, and it doesn't take on force, but it redistributes it, and it needs good hydration to do that. So you're putting a dead weight in there. There's no redistribution at all. And my guess is it's only going to add way more force above and below, which would be the end plates of the vertebral bodies, which when those start to become compromised, probably going to have more pain anyway.
And then you get facet problems and the compensations from there. Even with that too, we know if an ACL was repaired and a tendon, for example, elsewhere got put in place of a ligament, that tendon turns into a ligament based on the load applied. Now, that tissue is different than discs. I don't think we know to a certain extent, at least I don't, if you were to apply a cadaver disc of some sort into the body, would the body accept it and not bring resources there because it's a foreign object and just to kill it because of that communication from the immune system. But whether that can rehydrate the disc, that implantation method and how they go about that. There's also ligaments surrounding, there's connection points of small muscles around the spine. There's so many small things deeper to the spine versus everything overlying it that will have a huge effect. That there's a huge question mark there. But
and I have treated one patient who did have that procedure done.
Oh, cool.
And he was in misery every time I saw him. Awful pain every time I saw him. It didn't help him. That's all I can say on that. But that's where I fear that you think you can just resort to these interventions if things get worse enough. The real goal is prevent it before you have to have it.
That's so true.
And that's why obviously Doc and I talk so strongly about our profession, because we don't have to have you get there. And we don't want you to get there. And that's why we do what we do.
So Doc, I'm curious. So obviously we talked on stem cells. Now let's look at like osteoarthritis with exosomes. And we know that those are communicators from immune standpoint, but even directly for any tissue repair or any skin repair, wound repair, that it can also benefit as well. So what does it look like, exosomes with osteoarthritis?
Yeah. Theoretically, two main reasons, similar to stem cells. I'll just keep it at two. With stem cells, remember we had the secretory ability of it secreting growth factors, but also becoming a chondrocyte. And then it also has the ability to secrete anti-inflammatory cytokines to reduce inflammation. Exosomes are pretty close to those processes. They are just the transfer of it. So they don't secrete the growth factors, but they transfer them. They don't secrete the cytokines, but they transfer them. So that is why they believe they have the therapeutic effects, is because they're involved in the process that stem cells are also part of too. So it's really just, you take a look at why some drugs affect the same thing but different mechanisms, right? This is the same thing. It's like NSAIDs versus acetaminophen, where NSAIDs is more anti-inflammatory and acetaminophen tends to work more on the pain receptors, but both achieve pain relief.
Okay.
That's my guess to where they're maybe going to try to play around and understand why you'd use one versus the other, but both tend to get the same job done in a way. So looking at the research, we have a couple studies with exosomes on knee osteoarthritis. The first one was a pilot study. This was done on patients versus, I believe, placebo. Yes. And again, it just showed at the end of the results where pain was reduced. They had a better WOMAC score, which is a specific index used to assess osteoarthritis. And so when the scores are improved, it shows the osteoarthritis improved. And again, joint function also improved at the end. So cool. Patients' treatment was well tolerated, other things that they mentioned, and definitely some already good research showing that it's obviously it's safe, it's effective, and more does need to be done. But so far, the results are promising. Second study was done. This was a phase 1 clinical trial on patients with knee osteoarthritis. Again, over a 6-month period, showed decrease in inflammation markers, improved cartilage quality assessed by MRI. Not only did it have the effects of pain, but we also showed some effects on cartilage growth, which is interesting.
I know we touched on that too. Like, it would almost make sense as we're looking at between exosomes and stem cells, especially for osteoarthritis, just almost even potentially combining the two together, kind of like what you did in your previous workplace when you're utilizing some of those therapies. Like, if someone's going to go through with a regenerative medicine route, you might as well throw, to a certain extent, all that they can, especially in combination of these two together.
Yeah. And I would almost argue that's what you're going to start to see maybe is you're going to be doing stem cells with exosomes, or you're going to have definitely a lot more combination of regenerative products, because I think they do tend to work together. I know I've read at least a few studies showing PRP mixed with stem cells were more effective than just stem cells alone.
The fastest.
You get synergy, I think, with combining these products. And I think you're going to get, again, better outcomes when you figure out best concoction is a way to state it. So,
person specific.
of course. Yeah. And I wish we had all the answers right now, but eventually we're going to get there. And I can't wait for better protocols to come out. And eventually we talk about stem cells, but they're already building next generation stem cells. They're already building, just out of the vial is going to be the old stem cells. They're going to start genetically engineering better stem cells.
How the heck do they even go about that?
Yeah, from what I've been researching, it comes from we talked about Yamanaka, the Yamanaka factor of him taking a cell and then reversing it to a stem cell, any cell.
And this was the Nobel Prize winner in 2012?
Yeah.
Took, like Doc said, a dying cell.
Yeah.
And made it a living and alive.
Yeah.
Useful.
And so they're using his concept to promote the best stem cell from the best initial cell. So it's like how do you, I almost would expect it to be, how do you take an already really good cell and then make it into a better cell versus take a dying cell and make it in, like, I think that's how they're trying to put it into. But right now, the next generation, it's a cell that has been turned into a pluripotent stem cell. And the only reason that we don't know a lot about pluripotent stem cells yet is because you have mesenchymal stem cells, which a lot of the research is being done on. They're multipotent. So they only change into so many things. Pluripotent stem cells have a larger scope of being able to change into more things. But with that comes the ability to change into things maybe we don't want. And so that's where a lot more research has got to be done. But the ability and the potential we get with them far greater than just mesenchymal stem cells. So
That opens up the landscape.
yeah, and that's
Wow.
where you're going to see patients who have had cardiac death, cell death from a heart attack being possibly getting that revived,
Wow.
or brain death tissues. That's where I'm expecting that research to go in the next 10, 20 years. And all the other types of issues, whether that's, plaquing and things we feel like there's maybe not a way to reverse or eliminate. How can we then take that understanding and theory and then apply it to the things that Alzheimer's, dementia, Parkinson's, where something has been damaged so far that we're unfortunately stuck now with the degenerative effects of those diseases. So
Other than just monitor and help with some of the symptoms, actually fixing the root cause.
Exactly.
Yeah.
Pancreas death, diabetes, type 1 diabetes, and all the other things that we've felt like the stack of cards that were dealt were those cards, and you don't get anything else. So hopefully we can see some great potential in those types of conditions. What I'm most excited for is definitely brain TBI, spinal cord injury, post-stroke, and Parkinson's dementia. Anytime we can influence the brain in those ways, I know that's exciting for me. And the heart too. The heart is usually the first organ to go, is what they say. So if we can prolong that, how is that going to change lifespan numbers? I don't know. Very cool to think about, though.
You got to keep that ticker going. Okay. So let's look from like osteoarthritis for exosomes, and then let's open up to other joints. Because I know with the shoulder, I know rheumatoid arthritis from like an autoimmune stance. What is the effects with exosomes on those?
Absolutely. I'm going to take the same approach that we took. I have a rotator cuff study in here and an RA study, which is what I was able to find for both of the products. Lovely. I should say the tissues, maybe is a better word. So for rotator cuff, this was done in 2022. Patients receiving exosome injections from adipose MSCs derived. So the exosomes came from adipose mesenchymal stem cells, long down the line. Took fat, made stem cells, made exosomes. And they showed functional outcomes and pain relief compared to the control group. Also, MRI showed improved tendon healing and reduced inflammation due to chronic rotator cuff tear. So that was 2022. For RA, this was a trial that demonstrated exosome therapy significantly reduced disease activity, measured with disease activity score, and patients reported reduced joint pain and swelling. MRI scans showed decreased synovial inflammation. This was in 2021. So that was with MSC-derived exosomes. And so again, we're seeing the same, almost similar outcomes for both. The theory for exosomes, though, is a little different. It would be more of the migration of the cells that need to be signaled at the site of injury. So again, they're going to be carrying those growth factors. They're going to be carrying those anti-inflammatory cytokines to the area needed that are crucial for tissue health. But RA, it's interesting because they are acellular, so they don't have an immune response, but they modulate the immune system because they carry regulatory, T cells and other cells that promote or reduce inflammatory responses. What's so cool, though, is in terms of the brain, this one segment that I looked into, they actually inhibit the maturation function of dendritic cells, which reduce antigen presentation and subsequent inflammatory responses. It actually why people are using exosomes versus stem cells when it comes to the brain is exosomes can cross the blood-brain barrier. And so they can act on dendritic cells, reduce inflammation of the brain too, not just in other parts of the body as well. So right now, I think most providers are agreeing that if you're going to try and impact the brain, exosomes is probably the better choice because of that particular reason.
Man, okay. I'm just thinking, even theorizing to a certain extent, the utilization, hopefully projecting long term into clinics coming down the road. I could see exosomes being utilized a large portion with like physical therapy, natural medicine clinics that have rehab built in, so it can help for the signal to aid with the rehab that
Exactly.
they're doing. But like you said, synergistic effect or similar effects between stem cells and exosomes. You could probably go either or with that one, but I like how you brought up in terms of exosomes crossing the blood-brain barrier easier, which helps improve brain function and nervous system function a little bit more maybe.
Yeah.
But yeah, that opens up, then goes to Alzheimer's, Parkinson's, all these other conditions that, do you know if they have yet, because I know you just touched on this a little bit ago, does it help with, for exosomes for the plaquing? Is there any literature?
I'd have to look into that. I'm not sure, but I do know that I'm sure it's been looked at, and I'm sure they're looking at it right now. But I do know cognitively there is positive effects when patients who have those conditions do IV exosomes.
Wow.
I spoke with a woman in Florida who does a bunch of IVs for those kinds of patients. We've done some for our patients. I'm still looking to meet with other providers who are at the forefront of the brain to do a lot of these things. Exosomes were put on pause for a lot of providers for a while just because there was a lot of speculation around them. Still to this day, there's still some speculation around them. But right now, for the most part, I think it's more providers are starting to use them again. But I think what's interesting though is, you would even agree, is how many of these conditions that we treat are due to weak brain signal. And so it's okay, we continue to work with these patients, but if the muscle memory, it's just not kicking in, the signal just isn't getting there, and we're just not connecting brain to body. It's just not, for some reason, it's not working. And some of it's worse than others. Some patients who have had a full-on spinal cord injury, it's going to be a little bit different than someone who's got a chronic joint pain.
Yeah.
But it still can be a signal issue.
Absolutely.
And so why I'm so excited is because maybe this signal can be improved much quicker. Then we can do our jobs more efficiently.
It opens up.
And that's where you take this and you're like, all right, how do I run with this? Well, you don't forget what you've been doing. You add to it. It's not, oh, I'm just going to start injecting everybody and I'm not going to do anything else. It's not how it works. It's how can we continue to get those incredible results that we've been wanting for these patients that have maybe been struggling due to a weaker communication, what have you, all the other issues that can come from it. But that's what's exciting for me, because when these kinds of things pop up, I think about all the patients that I've struggled with that have had a tougher time recovering for whatever variables involved. And then I'm thinking, man, does this finally give us that boost, that extra, I don't know, tidbit that we need?
Theoretically, it would.
Yeah.
We're trying to use, I know us in clinic are trying to use all these properties of and ways to go about for the signal, let's say for the nervous system example on that connection, but to utilize that with other things that could theoretically potentially help as well. So for example, if we want to increase the nervous system's ability to communicate brain and body, it's increasing either local or systemic muscle contraction of just squeezing, bearing down all the tissues of the body, which can have an overlying effect, and that effect can last anywhere from minutes, more so up to probably half hour. So the literature is a little different with that. But that signal then can get filtered into different areas of rehab. So we utilize that with more or less patients in office, but can we have another helping signaler to aid with that connection? That's where the question marks are coming
from. And that's
from.
where, could we turn a 1 year full Achilles tear into 6 months or 3 months or less?
It's crazy.
Who knows? Because obviously when you go through an injury like that, that severing of that. You're losing so much tissue, including small superficial nerves, all the other things that can need to communicate. And so can we regain that much quicker, rehab much quicker, get them back? That's what excites me.
It's going to be fun, man. All right. So, Doc, let's end with a little bit of the exosomes and pain management, because I know we touched on stem cells. Is there a difference of pain management for exosomes? And if so, what does that look like?
Yeah. And I brought up stem cells in regards to just the studies that they really measured pain in. I did the same with exosomes, this study with osteoarthritis. So the exosomes that were injected for patients that had osteoarthritis, this was a double-blind placebo-controlled trial. So it was a very high validity trial, and it showed patients who had exosome injections higher reduction in pain, and actually I think they just measured VAS. Basically over 6 months, the pain, the analgesic effects of the reduction of pain lasted a lot longer than the placebo group compared to, I think, saline. So you take a look at exosomes versus saline at 6 months. Patients who had osteoarthritis in the exosome group had far better results in pain than those just in saline. And what does that tell us? It tells us that it's not just placebo. Exosomes aren't just placebo, not just something that you're putting into the body and placebo has an effect on. So it's something that you got to make sure that you need to measure and do research on. And so this did help us gain a better understanding of that. And then in patients with chronic low back pain, this was an RCT. Exosome therapy led to significant pain reduction and functional improvement in patients with chronic low back pain. And it actually, apparently this study showed MRI assessments that reduced disc degeneration and inflammation is what it's stated in the study. So I'd have to look a little bit deeper into the study just to show what they used to measure that. But we are seeing exosomes now being used more in these cases, and I'm curious to see application-wise what one would be better versus the other, or both if they need to be. But again, why are they working as good as they are? Again, they carry all of the anti-inflammatory components to the sites, but it does also have some neuroprotective effects to help with nociceptive transmission, nerve health, brain health, all those kinds of things. That, to me, this is by far the most exciting thing that I've been following over the past, I would say. I started researching stem cells when I was 19, so I'm 30, so it's been 11 years. And every year I feel like I'm getting surpassed by so much knowledge. And to me, being a part of it and researching and being at the forefront of trying to understand it as it continues to be researched, I still feel like we're so far behind. I mean, we are, and it's only going to continue to speed up. If you are a practitioner who is interested in getting into this, I would suggest sooner than later, because there's a lot of people in the mix of this right now who are trying to just learn as they go, and they're gonna be prepared and ready to take on the newer technology when it does come out. And so they're only going to be more, I guess, prepared and have that advantage since they've already been working with these kinds of things.
So now knowing that, who would someone listen to? What resources should they look into when trying to get caught back up?
Yeah,
as
for
quick
sure.
as they can.
At the forefront right now, I would say you can look at a lot of researchers that are doing this, and I would say there's 3 in the space that I follow mostly. And Freytag was one who I've showed 2 of his studies today. Zhang is another one. I just know him by his last name, but if you look up Zhang stem cell, he's by far been leading most of the stem cell research. He's been doing a lot, I think, for over many years. As far as providers using these products, you can find a mixture of them. I don't know if I want to give any providers really, other than, I don't even know, because right now there's providers who state that you need to do this only outside of the United States because there's, you got to go to Panama. But really, the guy that started this kind of thought process changing, provoking, who was doing it in the United States and then he moved out of the United States was Dr. Neil Riordan. And so Neil Riordan, he wrote a book. He's a good, I think, place to get started for physicians. Right now, I've actually been following a doctor named Dr. Adil Khan. And Dr. Khan, he says some things I don't quite agree with, but he is really diving into the Yamanaka stem cell, into the iPSC stem cells. He's actually in Japan right now. He's learning from the researchers who worked with Yamanaka and actually got all this started. And so I know he has clinics around the outside of the United States, a few places, Mexico. I think he's been in Panama, and then he's over in Japan now. And he's looking into, and I haven't even looked into it yet, but they're called Muse stem cells. And so I need to look into that moving forward. But I guess they're just a next generation stem cell, an exosome. And so I'm curious what those are going to be like. Maybe I'll have more information coming on a later podcast about them too. But yeah, really, you want to find the providers that have been doing this long enough to state the kind of things that I've been saying. They understand how they get their stem cells. They understand what the labs are doing with the products that they're getting. They're doing other things than just stem cells too. You got to do
so important.
You got to do more than just the injection. Understanding the nutrition value of weight loss, rehab, other parts of pain. You can't just influence pain biologically. We know that. There's got to be a psychosocial eval included in that. You can't just inject stem cells to treat your trauma. It's not gonna take away the trauma you had, especially psychologically. No matter what you try, there are still some things you got to work on there too. That's what I want to leave it to as far as patients. Go try to understand more from all these providers that are putting out good information. If all they talk about is getting procedures and treatments, then maybe have some cautious there too. I haven't done these procedures in, let's see, it's been over 3 years now, but I still educate patients on them. Eventually, I want to get back to doing these procedures. Absolutely. I'm out here just trying to educate. I'm not trying to sell anyone on these products. So that's where I would argue you want to try to find providers who are just trying to educate you on best practices and using best practices, not just selling stem cells to every person who comes through their door.
Yep.
So,
and for both of those points too, I think it's also very important for the practitioner that you're listening to, whether it's stem cells or any other therapies, for them to have a general understanding of multiple practices so they can see different points of view and different influences that it can have on the condition or what you're trying to treat and heal, which makes sense going back to the stem cells. There's based on the whole systemic effect, but also locally. With more knowledge and more research comes answers, which then drives us into different avenues and paths moving forward. So yeah, it's going to be fun and exciting to see how this kind of coalesces as time goes on.
What the next 5-10 years of research looks like.
Absolutely. And obviously, we asked the question where to get started. I think also a really good part is to get started with some of these podcasts. Listen to us dive into certain areas that are a little bit more deep, but also think about the layman's terms, because if you're going to be a provider and supply this therapy for individuals, you have to have a general understanding of how to communicate that with a patient. And I think that's where I like what we're bringing on with these podcasts, because it's, for most people, easier to absorb than most researchers when they touch on different chemicals or different things, very minute things within the body, to where it's hard to understand all this. But to have that general understanding on how to communicate, I think, from far as I can see from the research I've done of all these regenerative podcasts, I think we have by far the best, most layman's terms of how to explain things, but also go into depths as well. So, and
you get the best of both worlds in a way.
100%. And that's where I thank you for your knowledge and all that what you're bringing to the table, but even more to come, like even this new stem cell, you're just a wealth of knowledge that's we're going to help so many people. Yeah. Thank you. So
thank you.
Yeah. So obviously subscribe, like, comment, share, ask questions. We're here to help out in any way possible, especially Doc in this topic. By all means, we're here for you on that.
And really, when we say share, we do mean share, because we would love nothing more than to pay to have this actually sent to more people. But when we talk about this kind of stuff, we are actually censored. And we don't, like you've talked about, we don't get the ability to pay for these kinds of podcasts. We cannot promote these. So it takes everyone to help share this podcasts, these kinds of podcasts. Not all of them, but just the ones where we talk about the ones that they, for some reason, still feel like they don't want as spoken about on their platforms. So
regenerative medicine.
For sure,
right?
yeah.
So exosomes, all this. Yeah.
So we really do rely on word of mouth and sharing for these pods because we can't expedite that process quicker. If we could, we would probably try. But again, thank you guys so much for listening. We hope that we've delivered a great wealth of knowledge to you guys, and we look forward to the next pod.
Woo! Yes, sir.
Disclaimer, the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Thanks for joining us on The Functional Code. For more evidence-based health insights, subscribe, rate and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the Functional Code. Until next time, stay well, stay informed, and embrace the science of living well.